Type 1 and type 2 diabetes are fundamentally different conditions, although both result in raised blood glucose levels. Type 1 diabetes is an autoimmune condition resulting in the destruction of pancreatic beta cells and an absolute deficiency in insulin production. The mainstay of treatment for type 1 diabetes is insulin. Type 2 diabetes is caused by insulin resistance and is mainly driven by factors such as age, genetics, lifestyle, and weight. Treatment available for type 2 diabetes includes oral and injectable medications which improve insulin resistance and insulin production in response to glucose load. During later stages of type 2 diabetes, injectable therapy with insulin may be required. There is no single definitive feature differentiating type 1 diabetes from type 2. However, there are several clinical hints that point towards a diagnosis of type 1 diabetes. These include younger age of onset, often a normal BMI as compared to type 2 diabetes, which is often associated with a raised BMI, family history of autoimmune disease, initial presentation is often with diabetic ketoacidosis, and risk of ketosis. If you suspect type 1 diabetes, then the next step would be to perform type 1 autoantibody screening and a fasting C-peptide as a surrogate measure of endogenous insulin production. These are the autoantibodies to be requested: anti-glutamic acid decarboxylase, anti-GAD antibodies, islet antigen 2, IA2 antibodies, islet cell cytoplasmic ICA antibodies, zinc transporter 8 ZNT8 antibodies, and insulin IAA antibodies. It is important to note that some people with type 1 diabetes may not have any elevated antibodies, which is classified as antibody negative type 1 diabetes. A fasting C-peptide level paired with a formal blood glucose level can help diagnose antibody-negative type 1 diabetes. The presence of a normal or high glucose level with a low C-peptide is diagnostic of insulin deficiency. C-peptide is a marker of endogenous insulin production and is unaffected by exogenous insulin treatment. Some people who have been diagnosed with type 2 diabetes may have been misdiagnosed or could have a subset of type 1 diabetes called latent autoimmune diabetes of adulthood, or LADA. In this case, they tend to have at least one or more elevated type 1 autoantibodies, but may not require insulin treatment straight away. LADA tends to have a more indolent course compared to classical type 1 diabetes. All patients with type 1 diabetes need to be registered with the National Diabetes Service Scheme, or NDSS, under the type 1 diabetes category. Any reclassification of the type of diabetes will require re-registration. This allows access to certain subsidised products and services, including continuous glucose monitoring and the consumables for insulin pump therapy. In summary, it is important to distinguish type 1 and type 2 diabetes as this changes management. These conditions can be distinguished on the basis of clinical features, antibody testing, and C-peptide paired with a formal glucose level. Consider checking for type 1 diabetes or LADA if there is a clinical suspicion. People with type 1 diabetes should be referred to a specialist service.